evening all to the 83rd session of the weekly huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We are cardiologists working at Care Hospital. The weekly huddle is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily clinical practice. The idea is not to talk particularly science, but also to talk about what is more practical or what is more pragmatic in our daily approach. And typically we do that by discussing about a clinical case or a clinical topic. Today, we are talking about a clinical case, which I will brief you momentarily. This is not a speaker or an audience model, which means at any given time, if you have something to add, either you can raise your hand or unmute yourself to speak. Before you do so, may I request you to first let the other person finish his or her thought before you start with your question or your comments. As a courtesy, you should let the other person complete their thought. So with this, as a customary, I always ask Praneeth for his initial opinion, and then we take opinion from rest of our attendees. Once a while, we do invite a special guest on this platform who has a particular expertise on the topic that we are discussing today. And today we have Dr. Bharat, who is a consultant gastroenterologist at Yashoda Hospital. Thank you, sir, for joining, and we will get your impression about today's discussion once we have the case discussion started. So today's case briefing, and just to tell you the format, I will keep all of you muted for most part. So whenever you need to talk or whenever you need to add your thought, please unmute yourself before you speak. I will keep all of you muted so that there is no crosstalk between the discussion. So the case for today, it's a 70-year-old male. He has a previous history of hypertension, diabetes, bypass surgery, which was done around 10 years back. At that time, he had anterior wall MI, which led him to have moderate LV dysfunction, which he had been maintaining so far reasonably well. Over the time, he also has developed CKD with his creatinine hovering around 2.5 to 2.8. He was recently admitted under cardiology for acute decompensated heart failure, which we thought was precipitated because of severe anemia. At that time, his hemoglobin was 6. On routine evaluation during that admission, he was found to have iron deficiency anemia with low ferritin. His stool was positive for occult blood. At that time, he was treated in lines of heart failure. He also received 1 unit of blood transfusion, which led his hemoglobin to be somewhere around 8.5 ballpark after diuresis, which we considered acceptable. He was treated with IV and oral iron supplementation and was discharged home. Before discharge, because of his iron deficiency anemia, he was evaluated with an upper GI endoscopy, which was found to be normal. Lower GI endoscopy in the form of colonoscopy was planned, but it was reported as inconclusive due to poor bowel preparation. Historically, he does have history of recurrent heart failure hospitalization, at least 2 that we could gather from the history. Both were about 6 months apart, and they both seem to be precipitated due to anemia as well. We don't have clear-cut information available from those hospitalizations. They did not happen with us. At least in one of those admissions, he required blood transfusion, just like he required in this admission as well. There is also history of occasional bleeding per rectum, which previously has been attributed to hemorrhoids. And even this time in the colonoscopy, there were few hemorrhoids, but there were no active bleed that was noted at this time. Otherwise, there was no any frank bleeding or frank blood loss that we could identify during this particular index hospitalization that we had with this patient. As a part of his heart failure evaluation, a coronary angiogram was planned, but it was not done in view of CKD and anemia. The idea here was that there probably is not any acute ischemic syndrome. Probably this is the anemia that is triggering his heart failure. And also because of his CKD, we did not want to expose him to contrast. He's being medically managed for his coronary artery disease, which seems to be stable in between the heart failure episodes. His hypertension and diabetes, which are the other two comorbidities, which are under control. And as I said, creatinine hovers around 2.5 to 2.8. Now coming back to the discussion for today. He also had been complaining of chronic constipation. And essentially, we brought in this case primarily to discuss about constipation, which is kind of an oxymoron because we are talking about a person with multiple comorbidities to talk about something as basic as constipation. But this is one of his lifestyle determining problem in a way that he has never been comfortable because his constipation is what keeps him bloated and he doesn't feel good about it. He has tried multiple laxative combinations in the past with partial relief. He complains of hard stool. He complains of bowel movement that happens once in 2 to 3 days. And he has this sense of incomplete evacuation. He doesn't have any nausea, vomiting otherwise. So we are trying to limit our discussion today with respect to constipation, taking this clinical case in mind. So the discussion point for today's case is, does this patient need any further evaluation for constipation? Understanding that one colonoscopy was done initially, which was inconclusive due to poor bowel preparation, whether colonoscopy is even indicated for a constipation management. I'm sure each one of us have multiple patients who have been complaining of chronic constipation for quite some time. And then how to escalate medical treatment beyond what is usually prescribed. Now, this patient has tried multiple medication in the past, but most recently, he is taking lactulose and prucalopride. I have difficult time pronouncing. It comes in the brand name of Provit, that he takes 2 to 4 milligrams daily. How to identify red flags for constipation, like in this patient? Are there any red flags that we can identify? And when to refer to a specialist and whom to refer? Who is the better person to manage constipation? Because I believe constipation is something that every physician and every surgeon should at least know how to manage, because this is one of the commonly reported symptoms. And because we are talking about clinical case today, if you need any further detail about this particular patient, please feel free to ask in case if there is any additional information which will help you in decision making. So long clinical case, if there is anything you need a revision of, please let me know. I will be happy to provide you more information. I'm trying to copy and paste this data in the chat box. I'm having difficulty doing that, but I'll try to get it done at some point so that you can review the clinical case that we are having. So Praneeth, on to you. How do you see this patient? I mean, and then I will ask my attendees for their impression.
Yeah, no, good evening, everyone. So this patient who essentially is having constipation. Now, evaluating constipation, most of the time you, or at least I give them a course of laxatives and see. And if they are okay with their issues, then I usually kind of take it or stop the evaluation there and do not probe further. Here in this case, because he seemed to be having constipation for quite some time and it is bothering him, I would probably refer him to a gastroenterologist. And I believe the hemorrhoids that he is having is not a primary problem. It's probably a secondary problem because of his chronic constipation and straining at stools, which led to hemorrhoids. So rather than sending to a surgeon, I would be sending him to a gastroenterologist to see whether there is anything going on. Connecting the dots, probably this patient who is having iron deficiency, anemia, and equally some constipation. So some obstructive pathology is something that should be ruled out, and the bowel preparation being inadequate only says that we could not see something, and I think some effort equally needs to be done by looking at the other cause. So he is having iron deficiency, anemia, and he is having blood loss. So it's basically patient is losing blood, and if hemorrhoids are not significant enough to explain that anemia, then there probably is something else going on which needs evaluation. I find the challenge of preparing him for colonoscopy in this case because of his heart failure and also CKD, which I would be interested to know from the others as well as our guest speaker about how do we resolve about the preparation of colonoscopy, because for a gastroenterologist to look at the colon, he expect the patient to pass good amount of stools, maybe 6 to 8 stools, so that the entire colon is clean and he can visualize the colon better and give an opinion. But this requires patient to drink large amount of volume and the laxative, which is kind of contradictory from the both from CKD standpoint and heart failure. Maybe that was also one of the reason why his bowel was not properly prepared. So that I think will be challenge in this case. And how do we resolve this issue is something which I would be interested to know in today's session. And regarding therapy, other than giving that lactulose and other syrups, the oral drugs, my knowledge or experience is limited again, which I would like to know. Referring, I answered, and I red flags. Regarding red flags, I think any constipation which is probably not getting rectified by the regular course of lactulose or something should probably deserve a specialist opinion, and probably something like this anemia and maybe unexplained weight loss or other issues to hint, and probably elderly males, etc. I think should deserve a specialist opinion in my regard. I think I answered the questions, and if there is anything that I was missing, I'll try to answer them.
Praneeth, I think you addressed most of it. I'll just try to highlight few things that you said, and then I will go to Praveen for his opinion. So 2-3 things that I want to highlight: this constipation and iron deficiency business, particularly in elderly, it becomes very difficult. Constipation pathology leading to blood loss, leading to iron deficiency, versus constipation leading to poor appetite, leading to poor iron intake, and leading to iron deficiency. I think it can go from both down as well as up, which is the primary pathology. It becomes a little bit challenging at times to differentiate, particularly in cases like these where their oral intake is so low, and good luck giving them oral iron supplementation. They probably are not going to take because of their bloating and whatnot. That also creates trouble. You did mention about colonoscopy in the setting of heart failure and CKD. That is really challenging because of the volume associated, but also because of electrolyte imbalance. There has been reports of colonoscopy leading to major electrolyte shifts, particularly hypomagnesemia. And while it is well tolerated in otherwise a normal person, patients who have got significant heart failure, at times they can get in trouble because of these electrolyte imbalances. So whenever you are doing colon prep in heart failure patient, they should be very, very categorically monitored, and we should try to make sure that we don't keep prepping them again and again, because each prep is a high risk prep for that patient population. So I thought I'll highlight these 2 things. One is my confusion, and second is just FYI to the attendees today. So Dr. Praveen, how would you handle this case? How do you see constipation is a ubiquitous problem? Should we be sending all constipation patients to gastroenterologist? How do you see this case? Dr. Praveen Nagula.
Good evening, everyone, sir. Coming to this case, sir, this patient is having 3 issues. Patient is in a heart failure, so there can be an patient is having intermittent acute exacerbations and hospitalization, so there can be an bowel edema. Patient is also a case of CKD, and patient is having iron deficiency anemia. And considering his heart failure, hypertension, and all that, probably if patient is on calcium channel blocker, that is also the cause of constipation. He is a heart failure patient, so he might be on the long-standing diuretic therapy. So that would be again a cause of constipation. Iron supplements, they are also the cause of the constipation. Now, in a patient with chronic constipation, as far as I know, And patient with diabetic, they usually say not to use the lactulose, lactulol, that is the lactihep, to be used. And even in heart failure patients, we can use the bulk forming laxatives for the relieving of the constipation. Regarding the procolopide, I do not know, sir. And as a patient is a chronic kidney disease, the calcium supplements which we will be using, those can also lead to the constipation. So I would check the drug list of the patient and then see whether there is any of the provocating factors, and then advise accordingly, sir. Regarding the red flags, if all this has been controlled to the minimum and still patient is having, then I would be referring the patient to specialist. Hello, sir.
Yeah, thank you, Praveen. You mentioned calcium channel blocker. He's not taking calcium channel blocker. Diuretic, he definitely is on diuretic. His diabetes is long-standing. So some sort of gastroparesis I do expect. How much of that gastroparesis extends to colon, that I don't know. That is something maybe we can answer that question during the discussion as well. But small bowel gastroparesis I certainly would expect in this particular patient. Somebody mentioned about polypharmacy, identifying drugs causing constipation. So the kind of drugs that we think of causing constipation notoriously are opioids. Other than that, most of the drugs, while they can cause constipation, I don't think the routine cardiac or diabetic medication that we use explicitly causes constipation as a primary adverse effect. Again, if somebody can highlight me onto that, that I'll be happy to engage in discussion. But he was not on opiates, and he was not taking particularly commonly prescribed drugs like tramadol and whatnot. That certainly can cause dysregulation in the bowels, causing nausea, vomiting, and constipation and whatnot. So this patient certainly was not on those drugs, but he was on most of the routine heart failure medication that you would think of, and diabetic medication whatsoever. So that is the current scenario of this patient. Anybody has got any thoughts about this case before I move on and ask somebody else for their opinion? Dr. Bipin, I believe you work in, correct me if I'm wrong, you work in Jharkhand, right, Dr. Bipin? Dr. Bipin, are you able to hear me? Okay, maybe I'll get to Dr. Bipin in a second. Let me ask our guest today, Dr. Bharat is here with us. Dr. Bharat, you heard the clinical case. Okay, Dr. Bipin is online.
Yeah, I'm back, sir.
Yeah. Dr. Bipin, you are working in Jharkhand, right? Is that correct?
Yes, sir. I'm Jharkhand.
Okay.
I'm in Jharkhand.
So if this patient was to come to you, let's say heart failure is resolved, this person was to come to you, how do you see his constipation, and how would you take it forward?
Sir, being a family physician, basic primary healthcare provider, I kind of there is sir, a senior sir, no, Sankar sir. He used to give some tips on Ayurvedic medicines and home remedies as well. So what I have found is this chronic constipation. I don't know if it's correctable with increasing fibers and all those things. Heart failure is, if it's resolved, then as a family physician, what I suggest is basically lifestyle modification, little ambulation, and all those things which we all know. For increasing fibers, what I have seen personally is that bale, that wood apple, that provides a good laxative effect for our bowels. So I usually recommend either bale powder, which is available in the market, or if they can make it at their own, by their own, crushing the bale wood apple into pieces and drying it up and making a powder kind of. But usually it's now available everywhere. What I have seen is most of the laxative, which are, even good companies have Senna in it. And those people who are taking Senna, they usually get joint pains very soon. I don't know what it has in it, but they usually complain of joint pains within a week or two. So I have stopped using laxatives containing Senna and started using this bale powder or wood apple powder, or even its leaves as well.
Perfect. Thank you so much, Dr. Bipin. And last question, at what point you refer these patients to specialists?
In view of recurrent anemia, sir, I usually get stool local blood test done, which was positive here. Definitely, I would send them for evaluation if they have something else, some organic pathology. If they are not, getting better, they usually get referred to the nearest center where we have a gastroenterologist to look into the matters.
Perfect. Dr. Bipin, we may be losing you just momentarily, but we heard you what you were saying, that iron deficiency anemia to you itself is a red flag. And I cannot agree more. Iron deficiency anemia in the setting of constipation and whatnot, in the setting of stool for occult blood positive, that certainly adds to the diagnostic clue. Again, the dilemma there it comes. Patients who have got hard stool, they end up having a little bit of hemorrhoids here and there, and occult blood, when it is positive, whether it is coming from hemorrhoids or whether it is coming from a main colon or not, that often becomes a little bit challenging to evaluate. In fact, occult blood assessment, when you talk about from the US guidelines, the occult blood came actually for a cancer screening rather than for iron deficiency anemia evaluation.
Very true.
The investigation of choice for iron deficiency anemia is colonoscopy rather than occult blood. Occult blood always becomes a screening tool for cancer rather than diagnostic treatment for diagnostic for iron deficiency anemia. But I hear you. I think iron deficiency anemia in this setting is a red flag, no doubts. Somaraju sir writes diltiazem and verapamil. Sir, I agree. I think this is something that Praveen also mentioned, that calcium channel blocker can be attributable cause in these kind of situations. This patient, this index patient, was not on calcium channel blocker. He was on beta blockers. But definitely once a while we have patients who are on diltiazem or verapamil, and that certainly can interfere with smooth muscle movements like that of bowels. So I invite my attendees for their comments or suggestions. And while you do so, may I ask our guest to get his opinion. Dr. Bharat, if you could please unmute yourself and share your thoughts about today's discussion.
Good evening, Dr. Anoop. Good evening, everyone. Thanks for inviting me to this session, your discussions. Dr. Praneeth called me yesterday about this thing. So I basically, after hearing your case presentation, I feel that there are a few things which strongly point towards GI evaluation in this patient rather than treating him with symptomatic treatment or just modifying the drugs. From the history, I see that he's an elderly man who has congestive heart failure and kidney disease, who has been having constipation for a significant period. I assume it's more than 1 year. So from the history, because his constipation appears to be because of his slow transit of the bowel, because of his reduced bowel movements. It happens, he passes stool once in 3 days, and there is a lot of straining during defecation, and there is decreased effort to pass stool. So these are pointers towards slow transit. So basically, when we evaluate constipation, we tend to categorize them into secondary causes causing constipation, or it's a primary bowel problem, functional bowel problem. So in patients who have a lot of comorbid illnesses and who are on multiple medications, we tend to rule out secondary causes before considering it as a functional bowel disorder, primary bowel pathology. So from this history, a lot of factors can alter bowel motility in this patient. Like congestive heart failure can cause some amount of reduction in mesenteric blood flow, some amount of reduction in movements of stomach, bowel, and large bowel also. CKD also causes a lot of disturbances in GI motility, and which can cause constipation. The medications used for both these conditions, like for example, as you have mentioned, calcium channel blockers or diuretics, calcium supplements, these all can contribute to slowing of GI motility. So definitely he has a secondary cause of constipation rather than a primary functional bowel disorder. It can coexist, but there is a strong secondary cause which can cause constipation. Apart from that, there are 2 pointers in this case which definitely are alarm symptoms needing referral to a specialist. Those are his age is more than 45 years. Second thing is he has iron deficiency anemia. Iron deficiency anemia is a very strong clue towards evaluation of GI tract. According to the recommendations, if somebody has iron deficiency anemia, even in women in premenopausal age group, if they don't have history of menorrhagia, they deserve a GI evaluation, at least endoscopy and colonoscopy, before saying that it's a nutritional anemia. Because diet history is very unreliable. Diet can be secondary modified because of their comorbidities or because of their food fats and all these things. So it's very difficult to attribute it to nutritional anemia before doing a GI evaluation. So we tend to evaluate if there is no history of menorrhagia, even in women of premenopausal age group. In this case, an elderly man who has an iron deficiency anemia definitely needs a GI evaluation. So for this patient, the problems which I see are he was actually planned for GI evaluation, and upper GI endoscopy was done, which was normal. Then he was planned for a colon, but the colon prep was inadequate a couple of times. The reason what I see in this case is because of his slow transit, he requires a split preparation. So single preparation, bowel preparation, either on that day or previous night, may not clear his bowel. So he needs 48 hours preparation, slow preparation, splitting the preparation into 2 or 3, 12-hour periods. We can split the preparation and also modify his diet prior and optimize his drugs, give some enemas before giving preparation on the day of colonoscopy. These are some things which we can do to ensure that bowel is adequately prepared. We may not completely clear the bowel, but at least for some visualization to happen, it should not be solid stool in the bowel, impairing the vision of the scopist. So splitting the preparation into 3 or 4 bits and then giving enemas twice daily, optimizing the medications, changing his diet before planning a colon. These are some things which we can do. And also we should inform the gastroenterologist who is doing, so that he can arrange some things like flushing machine, because several of the endoscopy suites don't have flushing machine to do their colons or endoscopies. So what happens is that the nurse or the technician who assists the doctor, they keep flushing with the 50 ml syringe, and it's a very tiresome job. The scope gets blocked frequently, and after a point of time, they tend to postpone the procedure and do it on another day. And the patient has to endure all the things again, and he may not be willing for a second colon the second day or subsequently. So what we can do is we should have a flushing machine, a pump which flushes adequate amount of water through the scope, so that even if vision is not so perfect, we can flush off the material and we can advance the scope forward and take some time in observing the right colon. Because in this patient, the area of interest is cecum and ascending colon. Because if there was a left colonic pathology, they usually present with bleeding per rectum or abdominal pain or distension, because the caliber of the bowel is less in the left colon, while the caliber of the bowel is maximum at the cecum. So most of the malignancies are polyps in the cecum, high-grade dysplasias, which cause some amount of mucosal disease and cause bleeding. They usually present with iron deficiency anemia rather than causing abdominal pain or vomiting or distension. So in this patient, the area of interest is right colon, because somebody has examined the bowel, probably the left colon was examined, but the right colon, transverse colon might not have been completely examined. So in this case, doing a split preparation, giving enemas before, arranging for flushing during endoscopy, flushing machine, and then trying to put some effort to C till C-cum. That would complete our GI evaluation in this patient. If even after seeing the entire colon, if it's normal, there is no organic problem which can explain the iron deficiency anemia, I would do a contrast, CT with oral contrast in this patient. At least a non-contrast CT to start with of abdomen to see for small bowel lesions or some other thing which explains the iron deficiency anemia. So if that is also normal, then probably I would assume it to be nutritional anemia. That's what I feel in this patient, Dr. Anoop.
Sir, few questions that come to my mind as you were talking. Number one, which you partially answered, the CT colonoscopy. I remember hearing something like this during my residency. Is this what you mentioned by saying doing an oral CT or a CT with oral contrast? Is that CT colonoscopy?
No, I was mentioning about non-contrast CT abdomen,
okay,
not colography.
What is a CT colography? If you could just explain to our
we give it's a specific examination of the colon. We give contrast and then we examine the colon. We give bowel preparation and then we tend to do the CT. But then the sensitivity, specificity are not exactly comparable to a colon examination done by endoscopy. So it's not come into the routine practice of evaluating iron deficiency anemia. In some patients who refuse to do colon as a part of colon cancer screening, it is used in the West. But in most of the scenarios, especially in this patient, CT colography is not the correct tool to examine.
Okay, and then the next question is, this is split preparation or full preparation in heart failure patient. Is it something that you guys advocate to do inpatient in such patients who have heart failure, CKD and all this?
Yeah. These patients, we better to hospitalize them for planning because he has both CKD and CHF. He'll definitely go into volume overload if you don't admit and if you do the split preparation on OPD basis. So what we need to do is we ensure that dialysis timings are, probably he may require one more session of dialysis before we give some fluid, give around 750 ml of fluid a day. Next day again another 750 ml of preparation. Give some bisacodyl also, one tablet in the night, and then give twice daily of enemas, neutral enemas, so it doesn't cause electrolyte imbalance. So these things are some things which we can do. But we don't give a full preparation in the night and full preparation next day morning. It's not like that. For example, we plan to give 1 liter per day. So we give 1 liter or 750 ml the prior night. Then next day morning, we give another 750 ml. Then we can plan the dialysis in between or in the that day after giving the fluid to ensure that he doesn't go into volume overload.
And then the last question that I have for you is if you could just brief us about constipation management as a general in terms of the bulk forming versus vasoactive drugs, if that's a correct term. And other than iron deficiency anemia, what suggestions do you have to us in terms of if we see that we should refer it to you? I'm guessing somebody who comes to me with constipation and weight loss, that probably I should be suspecting malignancy in that patient. Iron deficiency anemia, we are talking about it. Is there anything else that you want general physicians or cardiologists like us to be looking and sending those patients over for specialized care? So 2 questions.
Yes, sir. So the first question, how to evaluate constipation in a patient who comes to a non-gastroenterologist. So, from the history, we try to identify whether it's a secondary cause causing constipation or it's a functional disorder of the bowel. So for that, we take some history, whether he has diabetes, which is uncontrolled, or he has hypothyroidism. He is on any medications which can cause constipation. Like the most common offenders are psychiatric medications like tricyclic antidepressants or some calcium channel blockers. So these drugs, then some systemic diseases like connective tissue disorders or kidney disease. So these things, if they are there, then we focus on secondary causes of constipation. If they are not there, if he has come with some atypical chest pain or something and he has constipation, then we assume that he may be having a primary functional disorder of bowel. So the things, we classify the functional bowel disorders into 3 types. One is normal transit constipation, second is slow transit constipation, third is dyssynergia. So normal, from the history, we ask the patient about what is his stool frequency, what is his consistency of stool. There is something called Bristol Stool's chart. So we, based on the appearance of the stool. So that gives a, if you have a picture of the thing, if you can show the picture of the patient, he can tell you what kind of thing is there. Because some patients have a subjective sense of constipation. It's not an objective constipation. Some patients feel that they are, even though they don't fit into the criteria of constipation, they are not happy with their bowels. So we don't need to evaluate them at all. We just counsel them that it's a normal thing that they're having. So it's always good to show them a Bristol stool chart. And if it's more than 2 or something, then less than 2, 1 or 2, then we consider it as an organic constipation. And then asking the patient about how frequently he has bowel movements. Usually less than 3 bowel movements a week, or more than 20%, 25% of the time. That means 1/4 of his attempts at defecation, he's having some problem. Like he's having passing hard stools, or he's passing straining during defecation, or he has to use some digital maneuvers for defecation. If all these things are met, then we label them as functional constipation. Okay. So secondary causes, then functional constipation, and then we focus on alarm symptoms. So if somebody complains of constipation, we see a checklist of a few things. The most important things among them are age more than 45 years and recent change in caliber of stool. For example, if the patient is having a thin caliber of stool, or it has changed recently, any recent alteration in bowel habits, that's a strong pointer towards an organic cause. Then bleeding per rectum, or recent loss of appetite or loss of weight, and presence of abdominal pain, distension, vomiting, any obstructive symptoms. Then if he has a family history of colorectal cancer, either first degree or second degree relatives had a colorectal cancer, or he has lost weight significantly, or he has developed symptoms of anemia. So these are some of the alarm symptoms which should definitely point us to an organic cause of constipation rather than a functional cause. So while you examine a cardiologist examines, takes some history about constipation, he focuses on secondary causes, functional cause, whether he has a really a constipation or it's just a subjective feeling, and he has alarm symptoms or not. So if he has alarm symptoms, then he definitely needs an evaluation from a GI person. So from then on, going further, so what tests to order in a patient with constipation? Do they really need any tests? So most of the people, if they fit into the criteria of constipation, passing less than 3 times a week or more than 25% of the times they have some problem in passing stool, there are some brief tests which we do are checking for fasting blood sugar, checking for thyroid profile, serum calcium, and checking the drug list, and checking serum creatinine and CBCs. So these things, metabolic workup and their blood parameters, these things are paramount. So if these things are normal, then we put the secondary causes aside. Then we focus on functional constipation. Then we choose between evaluation or empiric treatment. So if they have alarm symptoms, we do GI evaluation. If they don't have alarm symptoms, we treat empirically and see. So how to treat empirically in a patient with functional constipation? So the first thing is to increase the fiber in their diet. So usually we ask them to take 2 servings of fruits and at least 1 cup of vegetables, 1 serving of vegetables per day to increase the fiber. And we also add a fiber supplement to their routine, like giving them the most common fiber supplement which we give is isabgol, which is available in combination with lactulose or independently. So we give a supplement of isabgol in the night, and we ask them to increase the dietary fiber intake. The increasing water intake doesn't actually help in constipation. They'll pass urine more frequently. So if they're already taking 2 liters of water per day, no need to increase the water intake again. So then we give among the laxatives, which one to choose after fiber, what laxative to choose initially. So that depends on a lot of factors. So the most commonly prescribed laxative is lactulose, so which is a non-absorbed disaccharide, which forms bulk in the bowel and then it causes effective evacuation. So those patients who don't have bloating, though bloating is not a problem, for them we can prescribe lactulose. So if they already have a lot of bloating and abdominal discomfort, then lactulose will increase gas formation and it causes discomfort. So those who don't have bloating, we can choose lactulose. Lactulose, the problem is that its efficacy decreases over time. So usually in initial 1 month or 45 days, they'll have some efficacy. After that, it tends to diminish over time. So what we do is we give lactulose for a short period of time, maybe 1 month time. We start with 20 ml of lactulose at bedtime. Then we titrate according to the stool consistency and frequency. So the second option is to give a polyethylene glycol, which we give in bowel preparation. So we start with again 20 ml of syrup of polyethylene glycol, and then we mix in 100 ml of water and give, and then we titrate the dose according to the stool consistency and frequency. So polyethylene glycol has a prolonged effect. We can continue the medicine for some time, not like lactulose. So the third option is to give them prokinetics. So colonic prokinetics are procoloprid. That's the most commonly available drug. Other thing is lubiprostol, which is a chloride channel activator, which increases the water content in the stool. So we went to choose these drugs. So if they don't have effective defecation with lactulose or PEG, then we add on this colonic prokinetic. We start with 1 milligram of procoloprid in the night, and then we increase to 2 milligram per day. So it has been shown that it is safe in heart failure and CKD. So it's not a problem for using procoloprid in these two conditions. So maximum dose which we give is usually 2 milligram at bedtime. Sometimes some people give 4 milligram, but usually in the clinical practice we give limit to 2 milligram at bedtime, which is add-on therapy to either lactulose or plus fiber and PEG. So the third option to give is to give something like a magnesium sulfate and sodium phosphate. So it's available commercially as cremafin or cremafin plus. Cremafin contains magnesium sulfate and cremafin plus contains sodium phosphate in addition. So those patients who have a lot of bloating and those who don't have kidney disease or heart failure, we tend to give them this combination of cremafin or cremafin plus. So it's usually relatively healthy people who with functional constipation, we give this drug. So if they, in this particular patient, for example, in our case, we wouldn't be choosing cremafin or cremafin plus because of electrolyte imbalance. The third variety of drugs apart from bulk forming and colonic prokinetics are colonic stimulants. So these are something called bisacodyl, which we commonly use as Dalcolax. So these in the recent studies have shown to be safe in long-term use also. Apart from add-on therapy intermittently, we can some studies are there to show its safety and efficacy as add-on drug to PEG or lactulose. So we can choose around 5 milligram of bisacodyl at bedtime in combination with lactulose or PEG. So these are some of the options that are available to us. So those who don't have bloating, we give lactulose, and those who have concomitant comorbidities, we give PEG, or elderly people. For young and relatively healthy people, we choose magnesium sulfate or along with plus or minus sodium phosphate. And this second line of drugs are colonic prokinetics and stimulant laxatives like bisacodyl.
Dr. Bharat, I have a last question for you, and then I will move to Dr. Somaraju for his comments. My last question to you is, when during my training in US, there was this strong push, which I believe still is there, to do active cancer screening, colon cancer screening in people age 50 plus. I believe part of it is also because colon cancer is more frequent in Western Hemisphere. Could you just walk us through what is the status in India? Are we actively doing colon cancer screening? Is it on a selected case by case basis, or what is the current status that we're doing?
Yes, Dr. Anoop. In India, there is the prevalence and incidence of colorectal cancer is significantly less than in the West. So the recommendation in Asian countries is actually 50 years. But in clinical practice, most of the people wouldn't be willing to undergo a colonoscopy. For example, I presented about colorectal cancer screening in a hospital in an academic session. And the moderator physician who is aged around 60, so he was asked whether you had undergone a colonoscopy or not. So he was outrightly not willing to undergo a colon. So there's a lot of resistance in the population for doing a colonoscopy. Even those who come to us to the OPD with bowel symptoms, aged more than 50 years, convincing them for a colon itself is a big thing. So colon cancer screening has not reached its awareness in the public, general public, and acceptability is very less because of the preparation involved and because of the anticipated problems that may have during preparation or during colon. There's a lot of resistance is there. In the West, because of the incidence is high and because the insurance covers the colon cancer screening, so they are kind of tuned to doing it on a regular basis. Most of the colons in their routine practice will be for colorectal cancer screening. So the Western countries have actually changed it to 45 years now, while in the Asian countries we are doing it 50 years.
But do we have enough incidents to even justify doing a cancer screening?
Yeah, we
do.
But there is lack of, acceptability is the issue in our place. So once in 10 years, after 50 years of age, the Asian countries is the recommendation for those who are not normal risk of colorectal cancers.
Perfect. Thank you. Thank you, Dr. Bharat. If anybody has got any questions, comments, or suggestions, you can please raise your hand or unmute yourself while I ask Dr. Somaraju for his comments. Sir, you heard today's discussion, your thoughts on today's case and topic as a general.
Thank you, Dr. Anoop. And it's a very, very important issue and topic because more than 60% of our patients who come to our outpatient and almost 70 to 80% of our patients who are hospitalized have constipation. Actually, when you go for a round in the morning, the commonest complaint you hear is constipation, not chest pain. And having said that, most of the issues are very well addressed and most of these are already brought out, except I just want to add on only two issues. One is it's extremely important that patients with various clinical syndromes of heart disease, or for that matter, anything else, staining a stool is dangerous. And for a variety of reasons, I won't go into details. Whether it is ACS, or whether somebody has significant coronary artery disease, or post-CABG, or heart failure, etc., they are already, their blood pressures are already at borderline and they strain at the stool. And I won't go into details except telling you it's dangerous. There are instances of death in the washroom because of these issues, or arrhythmias occurring, etc. And secondly, coming on to screening for colonic cancer, the scenario is changing in India. People are living longer, and the incidence of colonic polyposis and cancer is increasing significantly in this country. It's time that we rethink at colonic screening more seriously and come to apply it in appropriate age groups and patients. Nothing else I add, and I learned a lot of interesting and important things. Thank you.
Thank you so much, sir. I concur absolutely regarding screening. In fact, I am pretty young in clinical practice, and I cannot remember how many times patients have been admitted to cardiologist service because of heart failure or an ischemic cascade triggered due to straining. So it is exceedingly important, and also in those patients who are recovering from MI and heart failure, I think it is our responsibility to make sure our patients don't strain. So that is absolutely relevant. I cannot overemphasize enough. Thank you, Somaraju sir. Anybody else has got any other comments about today's discussion that we are doing?
Good evening, Anoop.
Yeah, Rahul, please go ahead.
Yeah, just wanted to add on. I don't know if it was already said. I joined 15 minutes late. What I was taught initially in my medical ICU posting in critical care was blood itself is a constipator in the gut. So your patient having bleed in the gut, maybe the iron content of the blood itself is acting like a constipation. Can we do something about it?
Okay, so I actually read it the other way, and Bharat sir, maybe you can be the tiebreaker. I was taught that blood is a cathartic, And a person who is having upper GI bleed cannot have a constipation. Blood always produces more gastric motility than less. That is what I have been witnessing, or at least practicing so far, and that is why this common saying that if blood is there in your gut, it won't hide for long, it will come out because it will cause peristalsis. What is the verdict, Bharat sir? Blood in the gut.
You're exactly right. Because somebody with GI bleed, they'll have a rapid transit. Blood has a cathartic effect. So they'll have melena or hematochezia. So if somebody is with GI bleed, gets admitted with GI bleed and they're not passing stool, it means that the bleeding is less than 50 ml. So it's, for example, in this patient, probably his bleeding per rectum is because of his training, and the blood has come from the anorectal source rather than from the right colon or somewhere in the small bowel. So most commonly, his bleeding must be from the anorectal region. And his anemia,
sorry for interruption. Carry on.
yeah, and anemia might be probably because of slow blood loss from some lesion in the right colon or small bowel.
Exactly, sir. I just wanted to say here, most of the cardiac patients in cardiac ICU, they have a small ooze because of our antiplatelets. They may not be that bleeders. So what we see most of the times is the stool blood coming positive, but will not have an active bleed. So one small oozers, can they have constipation otherwise? Having some iron always in the gut.
Probably they may have a secondary cause of constipation rather than the right.
Yes, primary cause is heart failure, bowel edema. Top on this one.
Somaraju sir, you wanted to add something?
I just wanted to add, you already brought out by, I think, Dr. Praneeth. It's very important to emphasize where you are trying to screen for colonic cancer or evaluating a patient for a constipation, etc., or bleeding from GI tract. Don't take shelter under the diagnosis of hemorrhoids. And piles or hemorrhoids is almost normal in people. Don't take shelter under the diagnosis and miss a diagnosis, serious diagnosis of cancer of the gastrointestinal tract. Very important to keep in mind.
Thank you, Somaraju sir. Praneeth, you want to walk us through what happened with this patient and then give us your closing comments about what we are discussing today?
Yeah, so this patient who was under long follow-up with us, most important challenge was evaluating CAD, and every time the difficulty of evaluating the colon, and it kind of kept skipping patient electors and multiple factors, and he recently got readmitted again in a much sicker fashion, again heart failure, decompensation, anemia with a hemoglobin of 6, transfused. His CKD also worsened, and now his creatinine jumped to 4.5. We are planning to do dialysis, and after transfusion we could finally did colonoscopy, and we could see the bowel, and there's a huge mass in the ascending colon with gross findings suggestive of CA colon, and we took a biopsy of it, and then it was like the confirmed diagnosis now, and was kind of getting evaluated, stabilized, and explained the prognosis. And maybe after the diagnosis, after 3 weeks post this colonoscopy, we lost the patient. So that was the issue of long-lasting constipation, which kind of really played hide and seek because of multiple issues. Probably doing an aggressive search was something that we look back, and how much we should push was something that came up, and it really felt very bad that we missed a diagnosis of CA colon, and this made us that we should discuss this clinical case for a weekly huddle, and equally share our experience, and equally learn from each other. That was a painful finding that we found on colonoscopy and equally losing this patient was really sad. I would probably take comment from others on this, and maybe if there's no, and we'll close the session.
So Praneeth, talking about this case, I believe we were discussing about this patient early in the day. And I think that many of the times, while the symptomatology is so common that it can be justified why it misses our attention, but at the same time, this patient was giving enough indication for us to aggressively look after. And twice attempts were made to look for his bowel, and both the times the attempts couldn't succeed. So definitely this is something that tells us that probably we should have tried a couple of more times till we finally succeed. But there was enough hints in this case to tell us that there was a problem. His comorbidities certainly did not help, because everything to do in this case literally was challenging. An outcome like this was not totally unanticipated, understanding the background that this patient was suffering from. In fact, I'll share one more case, and then I will ask Dr. Bharat for his opinion about situations like these, and then we'll close the session. This one index case came to us a few months ago, where this patient saw at least 3 doctors in our outpatient department. The first 2 he saw only as a courtesy till he saw the gastroenterologist, and his presenting complaint was constipation. He actually came, he drove his car to the hospital, absolutely fine. His only problem was he didn't have a bowel movement for the past 6 days. And he was otherwise fine. He just had some discomfort in his abdomen because of not passing bowels. And he actually went to see his known 2 doctors as a courtesy. And he was jumped from one doctor to another. Finally, somebody told him that, no, you should go and see a gastroenterologist. He went to see a gastroenterologist. Gastroenterologist felt something funny. So he told him to go to emergency and get evaluated. While doing so, in further probing, he also complained of some shortness of breath. I got involved in his case by seeing this patient in the emergency, and he had lung crepitations, he had desaturations, and he has ECG changes of non-ST elevation, MI. He had ST depressions on his ECG. So somewhere the thought process went along the diagnosis of heart failure. Long story short, in a few hours, we lost this patient in the emergency itself. And before we lost this patient, at least we could do some preliminary evaluation. One of that evaluation was CT abdomen with oral contrast, like what Dr. Bharat was mentioning. And as we were resuscitating this patient in the ER, the CT scan, when we saw the pictures, there was obvious perforation of the small bowel. And this patient basically on perforation was presenting as constipation. In this case was a long constipation of 6 days. And even before we could react, he succumbed because of hypotension and sepsis and whatnot. I believe his cardiac findings were just a part of systemic compromise. He most likely was not having any primary cardiac pathology. So at least in the last few years, we have these 2 examples where the presenting complaint was constipation. In the index case, it wasn't the presenting complaint, but it was one of the highlight complaints. And in the second brief case example that I gave, the presenting complaint was constipation, which didn't give us any time to even react. Bharat sir, your quick comment about the cases that we are discussing, and then we'll close the session today. Bharat sir, your comments about the cases today?
Yeah, no. So I heard your second case. So what I feel is probably he might be having some partial bowel obstruction. So because of distension and proximal bowel dilatation, probably somewhere it gave way or something. Perforation usually presents with severe pain, and constipation is not usually the presenting feature. Probably maybe having some mechanical obstruction of the bowel, and because he may be having some comorbidities, and this cardiac event, as you said, must be a secondary thing at the end. So somebody who has a recent onset of constipation should prompt evaluation to identify mechanical obstruction. So that's one of the alarm symptoms that I have mentioned. So recent onset of constipation is a strong pointer towards a lesion in the bowel causing mechanical obstruction. This is the first case which Pranit has mentioned, and which is the topic of discussion today. So I feel probably he has gone far too way the time when we diagnosed. I'm not sure whether we have lost him because of we have not diagnosed the CA colon or not. But definitely he must be having anemia for some time, which must be worsening his heart failure, and it has become a vicious cycle. So one important thing which I wanted to mention is chronic constipation per se confers an extra risk of development of colon cancer. They have a increased tendency for development of polyps in the colon and consequently CA colon. So those who have chronic constipation, and if they're aged more than 45 years, definitely we should do a colonic examination. It's worth, even if they don't have iron deficiency anemia, it's worthwhile to do a colonic examination to screen for polyps and colon cancers.
Perfect. Thank you so much, sir. If nobody has any other comments, I would close the session. Thank you, Bharat sir, for joining, and thank you everybody else for sharing your thought. We do clinical case discussion like this every Wednesday. We start at 7 o'clock, and the joining link is the same for future sessions as well. I'll close this session now. Good night, and we will see you again next Wednesday. Thank you all. Good night.